Professor James Robin, who will present to us today important talk about circulating tumor cells and tumor microenvironment.
And the pointer? The pointer, we just use this? Okay, thanks. Good afternoon, and thank you very much for inviting me to speak on our ongoing research at MD Anderson. What we're looking at is, my lab is interested in micrometastases, and in particular, we're interested in looking at circulating tumor cells, cells that are cancer stem cells, and also circulating tumor cells that are undergoing mesenchymal transition. The outline of my talk is here shown on this slide, and this first thing I want to talk to you about will be the clinical relevance of CTCs in peripheral blood of metastatic cancer patients. Also to look at DTCs, or disseminated tumor cells, in the bone marrow of early breast cancer patients, and to talk about the relationship between the disseminated tumor cells and cancer stem cells. And in particular, to share with you some of our data on looking at epithelial mesenchymal transition that is induced by inflammation, and then to talk about some of the future directions. As you know, circulating tumor cells are epithelial cells that are commonly found in peripheral blood of patients with metastatic breast cancer or metastatic disease of other epithelial cancers. The challenge one has is that in these situations, circulating tumor cells are very, very rare, and for every one circulating tumor cell, there are 10 billion leukocytes surrounding it. So how is it that we are able to capture these cells? We've had an experience of over 10 years now of enumerating circulating tumor cells in patients. A brief history of this is shown here, where we're using one technology, and there's only one technology that has been approved so far by the FDA, and that is the cell save, or the cell search system by Veridex. In this system here, you're looking at you're looking at a blood sample that's drawn. It's then put through a machine, cell tracks, and in that machine is a black box, and I'll go through that in a minute. The cell is stained and then reduced or concentrated into circulating tumor cells, which then can be visualized by a digital scope. Basically, what you're seeing, as shown on this slide, that happens in that black box, is that the epithelial cells are stained or captured using an antibody to EpCAM, and then the cells are permeabilized and stained for cytokeratin as a hallmark of an epithelial cell. In order to distinguish those cells from the rest of the leukocytes, the cell is also stained with anti-CD45, which is positive on leukocytes and negative on the tumor cells. And lastly, they are stained with a marker to be able to detect a complete nucleus, so you can look at an intact cell. Using this technology, multiple metastatic or epithelial cancers patients have been shown to have many circulating tumor cells. Normal individuals and benign patients do not have these circulating tumor cells, but as you can see on this slide, in breast, prostate, lung, etc., many of these cells do circulate in the peripheral blood and are readily captured. In a 2004 seminal paper by Cristofanelli, it was shown that detecting these cells has clinical relevance and of prognostic significance. He showed that in a New England Journal paper that if metastatic patients had more than 5 CTCs, then they had a much shorter overall survival as well as disease-free survival compared to patients who had fewer than 5 CTCs. Subsequently, similar trends were shown in colorectal cancer as well as in prostate cancer patients, but this is in the metastatic setting. Since then, we've been able to look at our history over the last 10 years, as I mentioned, and we've then looked at meta-analysis of all of these patients, around 440 patients that we've had screened and detected circulating tumor cells in the last 10 years. On the next slide, you'll see the slides are built in the same format, where on the y-axis you'll see percentages of patients who are positive for a particular marker, and on the x-axis you see there are two columns, one of patients on the left that have fewer than 5 CTCs, and on the right, patients who have had at least 5 CTCs. And on this slide, you can see that patients who have more than 5 CTCs at first progression had more new lesions than patients who had fewer than 5 CTCs. If you look further now, you see that the patients who have more than 5 CTCs also had more than 2 new metastatic sites. And mainly the metastatic sites were consistent with patients who had visceral disease, and much more significantly than in patients who had fewer CTCs. And finally, when there were metastatic occurrences in these patients, they were mainly in brain also. But this is historical data, and Massimo Crispinelli is still looking at the data to be able to present it for publication soon. But the challenge was that this is in a metastatic setting. How does one detect microscopic disease in patients who are of early stages of breast cancer? While we were working on the metastatic situation with circulating tumor cells, Stefan Braun in Germany was working on bone marrow to see if he could detect these cells in bone marrow. Why bone marrow? It is hypothesized that many of the circulating tumor cells actually home to the bone marrow where they stay as resident cells, and for unexplicable reasons which we have no idea about at the moment, these cells get activated and then travel to distant sites for metastases. So what he did was that at patients who are undergoing definitive surgery, he requested them to have a bilateral bone marrow. The cells were then concentrated among the nuclear cells, put onto a slide, and then stained for cytokeratin. And he showed in a follow-up of 10 years that patients who had at least one of these cells in their bone marrow, which he called disseminated tumor cells, had a much shorter overall survival and disease-free survival than patients who had no DTCs in their bone marrow. A few years later, we expanded the studies where we showed that the majority of these disseminated tumor cells in the bone marrow were of stem cell phenotype. They had expression of CD44 and not CD24, and they may or may not have had alder-flow activity. So here you have two different stem cell subsets that we are able to detect in bone marrow of early breast cancer patients. We've had more than 5 years follow-up of these patients now, and in a paper recently we showed that if these patients had either of these stem cell subsets, they had usually a shorter disease-free survival and overall survival than patients that did not have either of these subsets of stem cells. But it's very difficult to get bone marrow all the time from patients. So we actually, at the time, instituted looking at circulating tumor cells in the blood of the same patients that were giving us bone marrow. And on this slide, you see on the left-hand side, I repeat myself, where it shows that if you have DTCs in the bone marrow, then you have a shorter disease-free survival and overall survival. And on the right panels, you see the same patients that had at least one CTC. Now remember that in the metastatic stance, you have to have at least 5 CTCs. But in the early breast cancer patients, if you have as few as one CTC, you are compromised, you had inferior DFS and overall survival. But this doesn't tell us much about the biology. We're counting. And I think there's only so much one can do with repeating ourselves counting. And we know that because of the technologies we have today, many of the cells, when they become more aggressive in their phenotype, they lose expression of EpCAM and are not able to be detected by the technologies that are currently approved. So we had to develop other technologies. One of the things that we thought about was that if CTCs are surrounded by so many of leukocytes, there has to be a role for the leukocyte to play on what happens to these CTCs. On this slide, you can see this is in the microenvironment of the tumor. The tumor consists of many, many cell types, macrophages, lymphocytes, you name it. And these lymphocytes are trafficking between the lymph nodes and the tumor site. So the tumors are secreting factors, attracting the leukocytes, and once the leukocytes get to the microenvironment, they then get activated and secrete other factors. In secreting those factors, they then induce different characteristics in the tumor cells, which are allowed to be released into the peripheral circulation, where we are able to detect them as CTCs. So we thought, what would we do? What are the factors that we'd like to study? So we did a very quick screen of the samples, plasma samples of patients, and found that in breast cancer, these three cytokines were very highly expressed. And as you can see by the slide here, it shows that many of them have very similar characteristics and properties, and that favor more aggressive tumor phenotype. So we looked at, in particular, looking at mesenchymal transition. And we show here that on the left side, if you're looking at an epithelial tumor, it's very, very well characterized. They almost look like a brick wall. And these cells are very susceptible to chemotherapy and to radiation therapy. However, upon induction to mesenchymal phenotype, that architecture breaks down, the cells become spindle-like shaped, they are more aggressive, they are more invasive, and more motile. And they are also less or resistant to chemotherapy and radiation therapy at that point. Simultaneously, they also lose some of the expression that they had previously. So now they are no longer E-cadherin positive, they acquire N-cadherin, they lose cytokeratin, which is a hallmark of an epithelial cell, and they acquire vimentin. In addition to that, they acquire many other different transcription factors, which I'll mention in a minute. So we asked the question, what would happen if we expose cells, tumor cells, that are of epithelial phenotype to products of immune cells? So we took normal donors, we separated the cells into T cells and monocytes. We then activated these T cells and monocytes either using a T cell activator for the T cell receptor, or using LPS, which is a activator of on monocytes, toll-like receptor 4 on monocytes. And we collected the supernatants, which we call conditioned media, after 48 hours. We then exposed the tumor cells to the supernatant for another 48 hours. At the end of that 48 hours, we collected the cells, we extracted RNA and performed PCR. But before we went down to doing the PCRs, we did characterize what was in the supernatants. And on the top panel here, you can see that there was about 40 different factors that were being produced by the supernatants. And many of them are elevated, as you can see. The black is when T cells were activated, and the white is when monocytes were activated. From this, we picked out 3 cytokines, which happen to be very similar to what we found in the peripheral blood, with TNF, IL-6, and IL-1, which are the highly expressed in these supernatants. We then exposed cell lines such as SUM190, IBC3, SUM149, and KPL4. These are different breast cancer cell lines that have got either HER2 or they are triple negative, etc. And we expose them to the different supernatants here. As you can see, on the first column is just medium. The second column is looking at unstimulated culture fluid for 48 hours. The third column is looking at supernatant from monocyte cultures, and the fourth column is looking at supernatant from T cells. And finally, the control was using TGF-beta, because we know that TGF-beta is a very good inducer of EMT. On the bottom, you'll see that we looked at different transcription factors that induce EMT. And if you use medium alone, is where we have a cutoff on the left. And if you go to LPS now, you see there's a little slight increase in some of the transcription factors. But when we expose the cells to the supernatants of T cells that were activated, there was a tremendous increase in these transcription factors. similar to what you would see with the control, which is TGF-beta in the last column. We then looked at the morphology of these cells, and if you focus yourselves on the two panels that are darkened, where it says US and SUM149 and anti-CD3, and you look down to where it says vimentin and cytokeratin 5 and 6, you can see there's a tremendous increase in these markers, which is consistent with a cell going from an epithelial to a mesenchymal phenotype. So vimentin and cytokeratin 5 and 6, which is an aggressive cytokeratin, is much increased in these cell lines. We then asked the question, what if we took specific cytokines now, off the shelf, TNF, TGF-beta, and IL-6, and exposed the cells, or incubated the cells in the presence of these cytokines. And as you go from left to right, you see that in the absence of any of the cytokines, the data are normalized to 1.
2 minutes, please.
And when you add TNF, there's a slight increase, but the maximum increase is when you have a combination of TNF and TGF-beta and IL-6. Okay. Now, we also were able to show that you can block this effect by using antibodies to TNF, TGF-beta, and IL-6. And as you see from left to right, as you add each individual antibody, there's a diminution in the expression of these transcription factors. We also showed that these cells were being signaled in the appropriate way. So we looked at phosphostat 3, which is signaling consistent with IL-6. And look on the bottom, we're looking at I-kappa B and B65, which is consistent with TNF. And again, you see in a time over hours and minutes, there is an increase in these transcription, in these signaling products. So finally, our working model is that if you have a tumor where they recruit leukocytes to it, they get activated. The leukocytes then produce factors which induce these cells to undergo mesenchymal transition. The mesenchymal transition, and the cells are released from the tumor. They're able to enter the circulation and also exit the circulation to go to distal site to form metastases. We're able to detect the CTCs that you see in yellow, but not very well able to detect the CTCs that look like stars, because these are have lost EPCAM, and we're unable to detect them except by PCR. So in summary, I've shown you that CTCs have a clinical relevance in both early as well as metastatic breast cancer. The majority of the DTCs in the peripheral and the bone marrow of early breast cancer patients have got stem cell phenotype, and that these cells can be induced into mesenchymal phenotype using inflammatory factors such as cytokines. The future directions that we have is that to collect enough CTCs to do a molecular profiling, to be able to get at the genome of these cells. And then we have an ongoing study now to look at whether there are genomic differences between the CTCs in the peripheral blood and the tumor cells in the primary as well as in the metastatic tumors. And finally, and in addition to that, we're trying to look at the role of inflammation in these studies. So these are my collaborators that I've listed, and here are our support for the studies that I've presented to you today. Thank you.
No, two questions, please.
There's one back there.
Thank you very much for the interesting talk.
Now I have the honor and the pleasure to introduce my dear Professor Dr. Nihat Ibrahim.
I still have a question, please.
Yes.
Sorry.
I didn't answer. Okay.
Go ahead.
Thank you very much for the very informative presentation. Well, this brings me back to the memories when I was working in blood monocytes and interaction with breast cancer and the cause of metastasis. So, was there any mononuclear antibodies tested for these circulating cells to try to explain to us why these cells have a higher incidence of spread to the brain, knowing the fact that the cell size by itself will be difficult to pass through the blood-brain barrier?
I'm sorry, I didn't get the last part of it.
Well, you mentioned that this patient was more than 5 CTCs per high power field.
Yes.
they have a higher chance of brain secondaries. And knowing that these cells, from the size point of view, they are difficult to pass through the blood-brain barrier. So how would you explain how they reach the brain?
Well, those data are not my data. Those are data presented that were being compiled by Dr. Christopher Nelly in Philadelphia. So I don't have access to those data. I just present it as what we are doing, trying to follow up on the CTC story that we had. So I don't know the clinical database of that yet.
Because we don't see if anyone, please raise the hand. Okay, thank you.
Okay, now I have the pleasure and honor to introduce my dear